I'm going to take a page out of Martina's book, and I'm going to read my script. I also have trouble managing time, so. Okay, great. So, hello, everybody. I, too, am super honored to be here amongst all of you brilliant colleagues, many of whom I had only communicated with virtually, and felt like I was sort of in this silo, this independent world, doing my thing on birth space design, but it's really energizing to be with so many people who feel, who share my passion and my vision. It's really great. Usually I get like weird looks when I start talking about this stuff, so I feel very at home. But today I'm going to share some of my recent work about transforming maternal health care in low-resource settings. My name is Deb Polzin Rosenberg, and as Liz mentioned, I'm a registered nurse and a registered architect, and I'm also a mother to two. And I've dedicated my career to improving the design of childbirth facilities around the world. I'm going to tell you a little bit about my unusual career path, because it's a question I get a lot. It really began in college after I read the book, The Red Tent by Anita Diamant. Many of you have probably read it as well. But I totally was hooked. I became super passionate about all things pregnancy and birth related, even though I was a psychology major, but my thesis ended up being about birth. I apprenticed with a certified nurse midwife at that time, working in our small community doing home and birth center births. And I didn't realize it at the time, but she had a very unique model for CNMs in the United States, spending lengthy prenatal visits getting to know her patients, providing very personalized care, and supporting birth in the comfort of a woman's home, or the small freestanding birth center she had converted from a single-family home in our small town just blocks from the hospital. So, inspired by Gretchen's practice, I applied to a highly regarded nurse midwifery program in the US, but I quickly came to understand how special Gretchen's birth practice had been. My training revealed that most births in the US, even those attended by midwives, occur in hospitals like the one where I trained, large academic medical center labor and delivery units designed to treat the most medically complicated deliveries, and that look remarkably like intensive care units. I also quickly became disenchanted with the typical pregnancy and birth experience, which involved cursory 10-minute visits that felt really rushed and impersonal, intimidating, unfamiliar, and institutional, rife with rules and interventions that seemed guided more by liability concerns than actual good patient care. Women and families seemed out of place in these clinical settings to me. I really appreciated my career in nursing, being witness to people's most vulnerable moments, solving problems, listening, working collaboratively. But as a nurse, I also experienced firsthand the impact of the built environment on patient and staff outcomes. The environment really does shape behavior. The way a clinical space is designed can affect safety, staff collaboration, and speed of recovery. It can affect job satisfaction and burnout. It can drive choices about treatment. The impact is real, and it has consequences for measurable health outcomes. I found myself mentally redesigning the facilities where I worked, or making note of layouts that worked well and others that really didn't. And I became curious about the ways that design could be a powerful lever for promoting health in both patients and staff. I graduated from the Rhode Island School of Design with a master's in architecture. And after graduate school, I was awarded a travel grant to research design models for childbirth in the UK and the Netherlands from this boutique-like hotel, or a boutique hotel-like freestanding birth center located in Amsterdam, to an alongside midwifery unit in a government hospital in London, which really opened my eyes to unique approaches to supporting women and families in birth. I was also heavily pregnant with my second child, and I seriously considered just staying. My own birth experiences have been really diverse, from a community hospital unit, which is unfortunately now closed, to a home birth in my living room, but also support for a molar pregnancy that required basically life-saving treatment at a large academic medical center. In 2016, in my role with Mass Design Group, an architecture firm in Boston and worldwide, I collaborated with a team of architects, obstetricians, and health system researchers to explore the impact of design on birth facilities in the US and on clinical care. Our novel research study design had us documenting and analyzing 12 diverse birth settings in the US, including a tiny freestanding birth center in New Mexico, and one of the country's largest volume labor and delivery units in an academic medical center. Our aim was to explore how unit design could drive patient care, clinical decision-making, and health outcomes, such as the rate of cesarean section at the facility level. Soon after, I moved to Rwanda in my job with Mass in 2016, and this experience was totally transformative for me. To see firsthand the conditions in which most of the world's women give birth was pretty shocking. Open wards of little privacy, bare concrete surfaces, many of them cracking or crumbling, stifling hot air or really cold, poorly lit, and often overcrowded. And I also observed that women often rely on the help and support of a female companion, but there is rarely space to accommodate them inside these facilities. And so they set up camp outside on the campus, cooking, laundering, and sleeping outside. And during that time, I worked on government district hospitals in Rwanda and health centers in Malawi, trying to achieve a higher level of care for women across the birthing experience, from designing space for companions who commonly provide this essential support during labor, delivery, and postpartum, to working within the constraints of the open ward that I was talking about earlier to offer some amount of privacy for new moms and babies. These 2 years in Rwanda imprinted a curiosity in me that led me to the research I'm going to share with you today. And in 2022, I returned to Africa with my family, and this time to Botswana, where we lived for 3 years. And I've only just moved back to the US a few months ago. So as we've been hearing this morning and last night, and I know many of you are already aware of, there's a growing body of research around birth space design and the important role that facility design plays in impacting the experience, but also health outcomes. But around the world, most birthing spaces don't seem to reflect this knowledge. The gap is especially stark in the developing world, where the stakes are higher, where a woman's lifetime risk of dying from maternal causes is 1 in 49. For the past 3 years, I was living and working in Botswana, where I had the opportunity to work on 3 research projects with an aim to, 1, understand what global guidelines for the design of birth facilities exist and what they say. 2, explore opportunities to adapt birth spaces to reflect culture and traditions. And 3, to work with local stakeholders to develop strategies for evidence-based design in low-resource settings. In 2023, I was awarded a Spark grant from an organization called Ariadne Labs, which is a joint center for health systems innovation at Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. And the purpose of this project was to really understand why there is this no-do gap, as they refer to it, and why it persists in maternal health facilities. So why do we have all this research telling us to do one thing, but then when you look in the built environment, this is what you see? But first, I wanted to ask, well, what are the guidelines? What does the research say? And not just for North America or Scandinavia, but what do we know are best practices for the design of birth spaces around the world? Our team spent 6 months conducting a multidisciplinary kind of creative literature review it was very multidisciplinary, including peer-reviewed research, facility design guidelines and standards from different countries, as well as clinical obstetrics guidelines, and kind of scouring them for recommendations that related to the built environment. We also conducted interviews with key stakeholders in global maternal health care, including midwives, obstetricians, nurses, architects, designers, and facility and public health administrators from an alongside birth center in India to a government hospital in Malawi to an academic referral hospital in Boston. And what we found were, first, that there's a real large disparity in the knowledge base around the world for guidelines. The distribution of research and facility design guidelines is really skewed geographically, as you can see from this map. So far and away, the majority of studies and guidelines were about and for European and North American settings. And this map is showing the distribution of facility design guidelines, but we saw the same general pattern among research and clinical guidelines as well. And second, the vast majority of peer-reviewed research explored what we termed perceptual outcomes of birth, like patients, clinicians, or family members' satisfaction or their preferences for various design features, rather than measurable health outcomes of delivery, like duration of labor, rate of instrumental or surgical delivery, rate of complications, infant APGAR scores, et cetera. And it's not that the perceptual outcomes are not important or significant, but I think it's relevant to acknowledge that sometimes those measurable health outcomes can be more persuasive depending on your audience. And then thirdly, our review identified over 60 common themes across sources. So we kind of categorized topics that were covered across these different resources. These included topics like privacy, infection control, windows, room size, bathrooms, companion amenities, lighting, ventilation, storage, and the list goes on. Our analysis organized these themes by frequency and also looked for patterns among geographic and economic development categories, so separating, comparing between low and middle income countries and high income countries. And then there was a subset of cross-cutting themes that appeared across our peer-reviewed research, the interviews, and the facility design and obstetrics guidelines. And these included this list I have here. So this concept of hominess, which may be a problematic term that I'll talk about a little bit later. Privacy, labor support equipment, beds, control, lighting, room size, unit layout and organization, cleanliness, companion amenities, supplies and storage, communal spaces, wayfinding, staff spaces, infection control, bathrooms, materials and finishes, safety and security, ventilation and filtration, windows, utilities like water and electricity, communication, collaboration, culture, and traditions. I think perhaps naively, when I started this project, I'd hoped that we'd be able to distill from our review a simple checklist, clear guidelines for the evidence-based design of global birth facilities that we could apply worldwide. But of course, it wasn't going to be that simple. When it came to the specific recommendations within each of those themes, there was quite a bit of disagreement. What kind of bed should be used and how should it be positioned or oriented in the birthing room, or the degree of control over lighting, temperature, and ventilation that the patient should have versus the clinician. Sometimes the needs of key stakeholders in these scenarios were in conflict, patients versus providers, providers versus the administration. But there also emerged a clear difference in priorities between low and high resource settings. A kind of hierarchy of design needs really emerged. For most facilities in low resource settings, the first priorities are basic infrastructural needs: reliable water, electricity, and enough beds for each patient. Operational systems for addressing maintenance and cleaning, and essential supply chain issues for basic medications and supplies have to be resolved first. One strategy suggested enhancing this idea of hominess by concealing medical equipment and supplies behind casework or head wall elements. But as one of my colleagues put it, you have to have the equipment and supplies before you can think about concealing them. So thus, one of the key questions that emerged from the research is how guidelines can be adapted for different global settings, given vast differences in resource allocation, but also with respect to culture. So in a workshop with Malawi midwives, I noticed some confusion around this concept of hominess or creating a home-like environment. Why, they wanted to know, would women want to give birth someplace that looks like their home, where they might have a dirt floor and sleep on a mattress on the ground? These questions intrigued me. At the same time, I had toured many public labor and delivery units whether in government hospitals or community health centers, that no matter the country, all seem to share a kind of barracks aesthetic. I wondered how culture could be better reflected in the built environment as a complement to evidence-based design, to create a familiar environment, at least. Perhaps home-like was not the right word. Looking at these photos of birthing facilities across sub-Saharan Africa, you can see a lot of similarities. They're dark, crowded, single-story concrete structures, typically within a sprawling campus connected by covered walkways. Almost always open wards for each phase of labor, delivery, recovery, and postnatal care. Ventilation is frequently poor. Air conditioning or heating units are not functional if they are present at all. And old broken down equipment and furniture are stacked in a corner somewhere. Economy is, of course, a big driver for most of these facilities, which are predominantly owned, staffed, and operated by local ministries of health. But there's also a lack of awareness that design decisions could impact patient outcomes. In 2024, I was awarded a grant from the American Institute of Architects to travel to 4 countries in sub-Saharan Africa: Mozambique, Malawi, Ethiopia, and Botswana, diverse in their level of economic development, dominant religions, languages, and colonial history. I wanted to visit and document public birth facilities, meet with local birth practitioners, but also immerse myself in culture to begin to understand what opportunities might exist, to integrate local traditions and beliefs, and reflect the culture in the built environment. Many of you are familiar with the inhibitory effect of stress. We've heard about that this morning, on oxytocin in labor and birth. And so my research was grounded in the idea that familiar elements of a woman's cultural milieu might offer this comforting, familiar environment that could promote more effective labor and a safer, more satisfying experience in childbirth. Moreover, in many of these countries, a central strategy to reducing maternal and neonatal mortality has been to increase these facility-based births with access to trained clinicians who are prepared to handle emergencies. However, studies show that in many cases, women find the facility to be unsatisfactory once they arrive there, and they return to their communities after a negative experience that may have included overcrowding, unhygienic conditions, neglect, even abuse, as we've heard, making them really unlikely to recommend the experience or return again. For each country, I spent time researching the history, current events, the government health system, beliefs and traditions, especially related to pregnancy and childbirth, where I could find it. And through professional networks, I connected with obstetricians and midwives who were willing to assist me in visiting a government maternal health facility, who were willing to be interviewed to learn more about the typical birth experience in their country and allow me to measure and photograph in order to document the existing space. These are just a few photos from the facility I visited in Mozambique. I also spent time observing and engaging in the culture in each of these countries, a short period of time. I'm not an expert, but these photos are from Ethiopia. These experiences helped me to explore ways that traditions and beliefs, as well as placemaking design elements, might be reflected in the birth environment. For example, in Mozambique, this looked like opening up a large underutilized foyer in the existing space to the outdoors for increased airflow, and transforming the space's function into an early labor lounge, like we heard about earlier, to accommodate women who may have traveled a long way to come to the hospital. Nurses told me that women in Mozambique like to drink tea in labor and eat traditional foods, and that they may often be accompanied by a female relative. So I'm proposing a beverage station that could offer familiar foods and drinks. And I looked at ways that decor could reflect the tropical Swahili coast aesthetic in the area, with arches and hand-carved wooden doors in white coral limestone walls, and woven grass or driftwood to celebrate local craftsmanship. Suggested changes to the flow of patient care were also made alongside these cultural elements to support safer and more efficient care. For example, in this case, it was recommended to relocate the delivery room so that it was closer to the nurse and midwife station to enhance their ability to observe patients. Similar methods were used to think through strategies to incorporate culture into a small peri-urban health center in Blantyre, Malawi, a health center adjacent to a large informal settlement in Addis Ababa, Ethiopia, and the country's largest government referral hospital in Gaborone, Botswana. I'm so grateful for the generous clinicians who shared their time and experience with me, offering guided tours, patiently waiting while I photographed and measured existing spaces, asking tons of questions. Invariably, they would share the challenges they face as well at the facility level, but also more broadly at administrative levels and beyond, at the level of the Ministry of Health and Government. I think Latif alluded to the fact that many of the staff are underpaid, and they work in pretty challenging conditions. It was discouraging to see on the faces of the staff, the midwives, physicians, nurses, a familiar look, became familiar, of resignation, of powerlessness to bring about change in their built environment. Finally, last year, with the support of a U.S. Fulbright scholarship, I was able to research some of these barriers more deeply and to develop strategies for working within these constraints to deliver evidence-based design in low-resource settings. And by 2024, I was already pretty deeply immersed in Botswana life by the time my 10-month grant began, so I was able to capitalize on knowledge of the Botswana health system, the university departments of architecture and obstetrics and gynecology, and the broader culture. This hospital is just down the street from where I lived. My goal was to work closely with local stakeholders in the maternal health system to understand the challenges and opportunities and to engage those same players to co-design low-cost, high-impact strategies for implementing evidence-based design standards in that context. With the support of the Botswana Ministry of Health and with the help of local colleagues and students, I was able to document existing conditions of health facilities at various levels of the public health system, including Princess Marina Hospital, the country's largest referral hospital in Gaborone, and Mafila Kosi Health Center in Tlokwang, a village outside of the city. I also conducted interviews with local architects to gain insights into the experience of working with the Ministry of Health on design of health facilities. And I conducted 2 workshops with a multidisciplinary group of local maternal health stakeholders, including nurses, midwives, obstetricians, architects and designers, and health facility and government level administrators. These workshops aimed to raise awareness, first, of the role of design in promoting better birth outcomes. It's kind of a topic that not many people are very familiar with. So we introduced the concept of evidence-based design. We offered a brief literature review, introducing the important themes from ours and others' research. And next, we used design thinking activities to generate Botswana-specific opportunities and challenges and vote to reach a consensus on their top design priorities. And the priorities that emerged for this group as most important were ventilation, privacy, respectful maternity care, overcrowding, equipment, cleanliness, facility maintenance, lighting, quality assurance, welcoming for visitors, access to outdoors, and administrative responsiveness. And finally, in small groups strategically composed of a mix of different stakeholder types, participants worked with different media and in discussion with each other to generate responses to how might we queries formed around those top priorities. At the end of this co-design session, we reconvened and shared our ideas with the other groups. And the beauty of this process was that some of the strategies were really clever, and really only this group of people who were personally experienced and invested in the provision of maternal health care in Botswana could have come up with these unique solutions. So for example, in answer to the prompt, how might we reduce overcrowding in Botswana's maternal health facilities? Some strategies were organizational around changes at the health system level, such as emphasizing normal pregnancy and deliveries taking place at the health center level to reserve space at Princess Marina for the most complicated cases. At the unit level, suggestions were made to reconfigure the existing space to allow for more patients. A lot of facilities have a lot of underutilized or inefficiently used space, I noticed when I would visit these places, or look at ways to make more efficient use of the existing space. And for example, one issue in the postnatal ward is difficulty maintaining visibility to all of these 5 open bays. Each of them has 10 beds. Okay, thanks. Patients are crowded into the 2 bays nearest the nursing station, many of them on the floor, as I think you saw in the photo. The other bays remain mostly empty, or reverting to an open ward for deliveries to make sure all patients have a bed. Another suggestion was to build a separate space for what they call mother lodgers, women who have recovered from childbirth but remain in the postnatal ward because they're staying at the hospital for their baby in the NICU. And these mothers need to be accommodated, of course, but they could free up valuable beds in the postnatal ward. And another prompt was, how might we facilitate companions and visitors in Botswana maternal health facilities? We heard from mothers and observed on the unit a restrictive visitor policy in the postnatal ward. Visitors are not allowed in the postnatal ward unless there are extreme circumstances. And this is for a number of reasons. One, the open ward layout makes it difficult to preserve privacy. And 2, there are generally concerns around introducing infection in a vulnerable population. And then there's also a cultural practice in Botswana called botsetsi, which encourages mother-baby isolation in the weeks after birth. In practice, this means that women have to leave the ward, going outside to an outdoor waiting space or elsewhere on the campus to meet a visitor, and they're not allowed to bring the baby, so they leave the baby with another mother in the ward. And recently, in recent years, there's been a shift in Botswana culture to wanting to have more paternal involvement in birth, but the way the spaces are set up right now just really doesn't promote this idea or reinforce it. So participants suggested building a separate meeting space for families that would be directly accessible to the postnatal ward, but would allow for comfortable private meetings with mom, infant, and dad, or another visitor. To address maintenance, participants suggested an adopt a ward program, which I loved. In Botswana, large national companies love the publicity that comes from making philanthropic contributions to different causes. So Choppies or Spar, which are some of the major grocery store chains, could sponsor a unit through a philanthropic program, providing funding to maintain, but also ensuring maintenance through accountability and reputation. And it's a really clever strategy, I think, that leverages nuances of the Botswana culture, basically shaming people into maintaining the unit. We also hosted a roundtable conversation, which is a concept that has roots in Botswana culture. They call these kind of village meetings kotla. And we did this to give architects and designers an opportunity to share some of the challenges and roadblocks they encounter in government design and construction projects in order to begin to strategize how we could realistically intervene to make some of these ideas happen. So we're still working on synthesizing the findings from this study and this project, and I continue to work closely with the University of Botswana Departments of Architecture and Obstetrics and Gynecology to select strategies from those ideas we generated to develop further. And we'll be working to secure funding to see some of these ideas implemented in the Princess Marina Hospital maternity wards that I'm very excited about. I also want to take just a minute to talk about the teaching component of my Fulbright scholarship, which was incredibly rewarding, but also an opportunity to raise awareness of healthcare design as a specialty in architecture and to help develop capacity for higher standards of health facilities among Botswana's next generation of architects. I co-taught a required research methods course for undergraduate architecture students, but reframed the course content to focus on maternal health design. This course introduced students to the physiology of childbirth, and if I accomplished nothing else, this alone brought me a sense of satisfaction in having introduced a mostly male class of 20-something architecture students to labor and delivery. We had a guest midwife come and speak to our class, as well as local architects from the Ministry of Health Facilities Department. And students conducted interviews with family and friends to learn about contemporary and historic local experiences of childbirth. And they were tasked with forming design research questions related to maternal health facilities in Botswana. So a couple examples are, the purpose of this study is to conceptualize how maternal spaces can be designed to incorporate the practice of botsetsi and develop an understanding of barriers faced by healthcare providers in incorporating botsetsi at the end of the maternal health period. Or how does the maternity ward's spatial layout affect staff observation regarding communication, visual and auditory senses when patients need staff? Neglect is a common complaint about the maternity ward at Princess Marina. They conducted literature reviews pertaining to their topic and collected data from the local government hospital or health centers. Teaching was another really important part of the Fulbright Scholarship, not only because of the cultural exchange and the fun of being engaged with academia, and the energy these students brought to their studies despite struggling with basic supplies like paper or access to industry standard equipment and software, but it was also a means of raising awareness of the impact of design on our work, our health, and our communities. Some of the challenges of conducting this kind of research I think are worth touching on. I found even as a nurse and architect, it was difficult to gain access to maternal health facilities. I don't know if anyone else has had that experience, but I think particularly in sub-Saharan Africa, the cultural norm of avoiding topics that relate to sexuality in any way is very strong. And I think that contributed to the difficulty I had sometimes in explaining what I was trying to do. It's also a novel area of research even here. I really relied on having local colleagues helping to smooth the way where they could. It was really important to have those partnerships. And it's also, one of the more vulnerable areas of a health facility. Pregnant women who are wandering around naked. So that makes it a little difficult. But to me, the challenges of documenting these low resource facilities is really important. These spaces feel like a black box, honestly, with very little in the way of post-occupancy studies, for sure. But even like journalistic exposés that reveal deficiencies in units that other hospital departments might benefit from, like the emergency department, for example, would be like a high-profile case. But with some patients, persistence and help from many generous and passionate people, I was able to really begin to understand the gaps in translation from research to practice, to explore opportunities to reflect local culture and in the built environment, and to design economical strategies for providing high-quality care even in the poorest settings. I returned to the US very recently in August, and the political situation has really altered since I left. It's really nice to be in Canada this week, I have to say. And sadly, there are plenty of opportunities to improve care of pregnant and birthing women here in the US, where we're having our own crisis of maternal health, with the worst maternal mortality rate of any developed country, and worsening. Extreme racial disparities, and growing swaths of the country that lack basic access to obstetric services, so-called maternity deserts, especially in rural states like Maine, where I live. Small community hospitals were already struggling to keep their labor and delivery units open due to operational costs. In the past 10 years, 11 hospitals have shuttered their labor and delivery units, including 4 just in this last year alone. The result is that the average rural Maine resident has to travel 45 minutes to her nearest birthing unit, and some people much farther, obviously. And recent federal cuts to Medicaid have increased the pressure on those parts of the country without access to care. I just recently joined the healthcare design team at Shepley Bullfinch, where I'm exploring opportunities to build on lessons learned from these low resource settings to transform maternal health in the United States. I appreciate that design is not a cure-all. Global disparities in mortality, barriers to access, disrespectful maternity care can't be solved, I appreciate, with architecture alone. But the built environment does shape the birth experience in important ways, and design is a powerful tool that can be leveraged to reimagine not only our physical world, but can shape the behaviors and systems that support optimal care in childbirth. I'm incredibly grateful for the opportunities I've had these past 3 years, and want to offer my sincere thanks to the Ariadne Labs Spark Grant Program, the AIA New York Stewards and Keefe LeBrun Travel Grant, the Fulbright U.S. Scholar Award, as well as the colleagues at University of Botswana, students and participants who share my vision for a safer, better experience of birth around the world. Thank you.